All right. Welcome to the look back of Airway Assessment with Dr. Benzing, and I'm here also with Dr. Walker. Great podcast. Appreciate you coming down to Orlando Medical Institute to do this podcast. Today's podcast was on airway assessment. He talked about management of an airway, assessing the airway, talked about capnography and positioning and how to identify a difficult airway. So let's just recap on a few things you talk about. Anatomy is anatomy. I think the airway doesn't change from person to person. Maybe the significant change is between a pediatric or an infant, pediatric and the adult. You did talk about position. You showed an awesome slide of the three planes and how they line up.
Yep.
One technique I do find to work significantly almost 100% of the time is when you have that difficult airway that you have to assess or intubate, I should say. I get the questions of, do I pad the head? Do I pad the shoulders? Who I pad the shoulders? Who I pad the head? So I use a rough rule or a great rule of thumb is I look at the ears and where they're lining when my patient is supine. If the ears, I want the ears to be actually at the anterior part of the chest or shoulder. So if they're back here, then obviously I have to elevate the head.
Right.
If my ears are way up here, then I have to elevate the shoulders. So that's going to determine do we pad shoulders versus heads. So we know in small infants, the largest part is the head, so we pad shoulders. But the adult, we most likely have to pad the head and then put it in this new sniffing position. I see a lot of medics out there, when they can't get a difficult area, what they do, hyperextend the head even more. And to me, it actually complicates the area. What's your guys' thoughts on that? You guys follow the same type of theory?
Yeah, I think when I first started intubating, I learned from someone who would always put a pillow behind them. They're always get your pillow, always get your towel. And somehow it worked for them. But then on third attempt for me, I'm I got the pillow, what's going on? It's not happening. And then I happened to grab the head one time and pick it up. You just do all kinds of things when you don't know. And I'm whoa, look at that view. And so after thinking about it and then reading some more, similar to what you do, I've always learned now that the key is getting that tragus line with the sternal notch. So you'll see me kind of look at eye level and making sure. If they don't need anything, then they don't need anything. If that sternal notch is already lined up, so you might not need pillows, you might not need towels. But then it's how many do you need? Then always look at that line. There's no rule of thumb. We need 2 towels or we need 2 pillows.
Everybody's anatomy is different.
Exactly.
So, but line up the planes is line up the planes no matter what their anatomy is. Right.
Once I learned that was extremely helpful in the positioning part. And so hands down for any intubation, that's what I'll do very first.
There's nothing that's universal for every patient. Every patient, their anatomy is going to be a little bit different. There's some guidelines, pediatric versus adult. Of course, obese bariatric patients are their own, kind of present their own issues. But yeah, you kind of called me out. I think probably should have mentioned that your rule of thumb on my video. So make sure you guys watch this podcast. So you don't miss that part. I forgot to mention that in my presentation.
But when you was talking about it, you showed that slide. That's what came to my mind.
And that's what that's depicting.
And I teach cadaver labs throughout the country, and I do airway, and that's one of the things I show them. Actually, I'll do just do your airway. See, I want to see what you do once you intubate or you struggle to intubate a difficult airway. And everybody, almost 90% of people will hyperextend the head, and then they struggle, Then what happens at that point, we start prying, we start doing things that could be detrimental to the patient. So, now getting into airway management is a big thing. You mentioned in the podcast, I was man, he hit the nail right on the head. Without an airway, what we have? Nothing, a dead patient, Not to get quickly off topic, but I was that medic who will never do a surgical crank. Never. When I came out of medic school, never. We were trained in it, we could do it, and I was oh my God, I would never do that. And why? I was very uncomfortable doing it. I kept saying in my mind, I would say, man, imagine I cut him wrong. What if I make a different mark? What if I miss and then I have to do a second? And a surgeon once told me, because I brought in a patient that had unmanageable airway,
Yeah.
and it was a trauma, significant trauma to the head, the face, and I was ventilating, but obviously my ventilations were completely inadequate.
Mm-hmm.
And he asked me, he says, "Hey, why didn't you crike him?" I said, "No, doc, you know." He goes, "It's in your scope of practice. I'm sure your medical director allows you to do that." I said, "Yeah, but, you know, what if I, you know, cut the tissue, jack it up?" He's like, "You know what I am? I'm a surgeon. You know what I do? I fix tissue." One thing, he goes, "One thing I don't fix is dead."
Right.
So he says, if you jack up the tissue, I could fix that.
Yeah.
Okay, maybe it wasn't the prettiest surgical crike,
Right.
but I could fix tissue. He goes, "One thing I can
That's true.
absolutely not fix is dead.
Yeah.
So don't bring me a dead patient." And I was like, wow, that makes all the sense in the world. I wish I would have learned that in medic school.
You know what? I'm scared of doing a Craig too.
Yeah.
You know, that's-
Yeah, nobody wants to do
It
it.
is a procedure of desperation.
Yeah.
It is your last ditch attempt to secure that airway. And we actually had just a couple weeks ago one of the paramedics who did.
Yeah, he did a fabulous job.
Yeah.
Yeah.
It was fantastic.
So
Yeah.
let me ask you a question. And so for medics who are out there and say, "Oh my God, I'm with you, Felix. I'm not doing crikes
Right.
neither." But sometimes, I know there's no black and white patient who gets a crike, but if you could give me a zip code of patients, you know, I don't need something so broad, so specific, maybe a little bit broader. I mean, who would be the patient that I might consider that crike? Would you agree, head, facial, multi-trauma patients that
Yeah.
maybe I attempted an airway and I know it's unstable, so do I go to a supraglottic airway, try, I don't know if I'll be successful, or should I just go right to a crike?
You definitely shouldn't go right to the crate.
Okay.
I would say that. I mean, even in the ER, managing the airway, when we have anesthesia there and we have surgery there, I mean, crike is not our first answer either. If we can intubate, we'll try to do that. So I think following your EMS protocols, they'll tell you how many attempts you get. So for us, particularly, it's 2 attempts. If it's medical, for trauma, it's 1 attempt. So after that, if you are trying to intubate and you just can't, for some reason, get it in there, the next step is you can try a supraglottic. You know, this is assuming that you've tried to bag and that's not working.
Yeah.
So already they're a can't ventilate type of
Right.
patient. So now you're trying to see, can you intubate? So you try intubation twice, that doesn't work. You try the supraglottic. For some reason, maybe you aren't getting in tidal or it comes up. You know, there's not a good seal.
Or severe deformity in the anatomy.
Yeah, exactly. So at that point, then you want to do the crack. So the purpose and the point I'm trying to get across is it needs to be a stepwise approach. It does not need to be a very chaotic saying it's already going to be chaotic.
No.
You're already going to be clenching
We don't need to
sphincters.
add to that.
Yeah, you don't need to add to that. So you need to already think about any airway, think about your approach. So try your attempt. If that doesn't work, your supraglottic. Again, if you can't bag valve mask, because that's always going to be your backup. But if you can't, then you have to go through a crike, and no one's going to fault you for it. That's what you have to do.
So don't bring in a dead patient.
Right.
Yeah.
And that's what I was trying to highlight in the presentation as well is remember your basics. When it comes to airway, start with your basics and then move forward from there.
Yeah.
So if you're able to ventilate with bag valve, if you can do that and you're
good.
transporting,
Mhm.
as long as that person's ventilating,
Right.
then you're good. You don't need to make it more complicated than that.
Right.
Yeah.
If that's not working, that's when you start going into more complicated airways. And then
Yeah.
if like intubate or like LMA, laryngeal mask,
Right.
if that's not working, then intubating. If that's not working, trach is always going to be your last
Right,
desperate
right.
attempt.
Absolutely.
I like what you told the students one time when we were doing the airway lab. You were saying this plastic tube doesn't matter. It's the air that comes from up
Right,
here.
right,
So
right,
however
right.
the air gets into there, whether it's through bagging,
Right,
whether it's through a
right.
tube, it's not the actual act of putting the tube in. It's just
Right.
that they need to be getting ventilated.
Absolutely.
Right.
So BVM is not a failed option. I mean, that's
Absolutely.
a very viable option. And in fact, kids, we prefer that.
Right.
A lot of the new pediatric cardiac arrest data are showing that we prefer the BVM
Than
and
the
intubation for
right.
the, yeah, exactly. So,
If it's
And-
not broke, don't fix
Fix it,
Yeah.
right, right.
If you're bagging, fine.
right.
Right,
exactly.
and then I would
The
say
risk
there's always some exceptions to the rules.
Mhm.
I think one of those exceptions to the rule is, okay, I have this patient with significant head trauma, with that GCS that's sitting around, 8, 9, got trismus. I know it's not it's a matter of when this patient is going to start to vomit, right, from all that
Right.
pressure.
Mhm.
So that's a patient that I might be successful with ventilating, right?
Right.
But I need to try to secure an airway because aspiration can be detrimental to the patient. So now, in that situation, I might be successful with BVM, but I'm taking the
Sure.
second step of, it's not only about ventilation, it's about securing that airway so
Right.
when he vomits, we don't lose our patient.
Or if their condition is worsening, like angioedema, you have swelling, and it's just not going to get better, and they have an okay airway now, but you do need to anticipate, are they still going to have a good airway 20 minutes by the time you get them to the hospital?
Right. Yeah, that's why protocols will be different depending on how far out you are from the hospital too, because this ambulance service who has 45-minute transports, well, they may be doing more crikes
Right.
than the ambulance service that has just 15-minute transports,
Right.
because they can bag the entire time. But like you said, you get an angioedema an hour away, that patient
Right.
needs an airway sooner than later.
Or
Right.
smoke inhalation would be another.
Yeah,
Yeah,
good
that's very
example,
good. Yeah, that was big.
Anaphylaxis, right.
And they might look great when you roll up on scene.
Right,
Fine, but it's very quickly that they can go downhill.
right.
So let me ask you, so back to talking about adequacy, because that's important, right? Well, airway is one, establishing airway, whether we do a head tilt chin lift, whether we do modified jaw thrust. But I think we struggle sometimes to identify the adequacy. When do I say this is adequate versus inadequate? I know we look at tachycardia, we look at pulse oximetry, as we mentioned, and I want to make it known to everyone out there that pulse oximetry is not a tell-all.
Right.
Just because my SAT says 88, oh my
Right.
God, we lay them down,
Right.
we sedate them, put them out, and we intubate them because my SAT number was 88. We got to look at the big picture,
Right.
right? The presentation.
Right.
So mental status, I say, plays a big role,
Yep.
right? Probably one of the most significant, right? If you had an altered mental status, we're probably later on in the game.
Right.
Tachycardia.
It shows that something definitely is going on. Back to our shock module that we had and we talked about. That will alert you to like there's some sort of compensation going on for something. So if it's an airway issue and you're tachycardic already, then you're already kind of behind the 8 game. You need to be figuring out how you can manage the airway, the breathing, and circulation for that. But I think one of the most important things recently we have is end-tidal for that. Like you said, with the O2 saturation, that could still be 90 for quite some time.
Right.
Your end-tidal will show changes faster than your O2 sat will.
Right.
So if you can look at end-tidal changes, in addition to what you say, mental status, I think you'll be fine.
Right, and then Doc, you brought up a good point about no innovation, smoke inhalation. That also can alter pulse oximetry.
Mm-hmm.
Carbon monoxide.
Carbon
poisoning.
monoxide
Fingernail
Fingernail
polish,
polish,
yeah.
yeah.
Anemia.
Yeah.
I mean, there's a lot of reasons why you might not be able to lose
Right.
your
Even one of the ones I also mentioned was high altitude.
Yeah.
Yes.
Polycythemia, you have
Yeah.
increased concentration of hemoglobin
Mhm.
normally, then you're going to have naturally a lower
Right.
saturation.
So, Dr. Walker, you mentioned, and some great caveat into capnography, which is huge in EMS. We've been doing it for many years, and to me, that's a gold standard for innovation.
Mm-hmm.
And it should be everybody's gold standard, no matter if you're a physician, nurse, paramedic, whatever. If you have the ability and the capability to use end-tidal, use it on intubated patients. And so you talked about numbers. You talked about a capnography less than 10 millimeters of mercury versus greater. So if I have that code initially, this is where I like to be real clear with paramedics, is when you have a code, initially there's no circulation. We know that. That's why they're in cardiac arrest. So I expect the number to be low, maybe even less than 10.
Right.
So it's not the start point of 10,
Right.
is when we intervene with resuscitation,
Right.
am I still less than 10, right?
Right. Yeah.
Is your intervention adequate?
Right. So yes, it's good to get the initial, what the initial is, but where I'm at with adequate and sufficient chest compressions and ventilations. If I am doing great chest compressions, great ventilations, and doing all that, medications, whatever, run your code the way you need to run it, but doing it correctly and adequately, then that number should change because we have circulation.
Mm-hmm.
Right.
So I think that's where we fall off sometimes. I think we say, oh my God, my initial capnography is 10. All right, he's dead. But there was no resuscitation. It's kind of like the
Right.
innovation I mentioned too.
Mm-hmm.
Yeah.
I used to say, if you have a flat line, when you intubate, that means that the tube is in the, there's no ventilation, right?
Mm-hmm.
So all the tubes in the wrong place, I should say. I used to say that all the time. Oh, drop the tube in, put the capnography,
Right.
flat line, tubes,
Oh,
no tubes in the wrong place. I no longer say that.
Right.
You know why? A medic proved me wrong, because a medic dropped the tube, put the end-tidal CO2,
Yeah.
and looked at the monitor and saw a flat line.
Mm-hmm.
Right.
But he never hooked a BVM.
Right.
So I say, if is flatline,
Right.
there's no ventilation.
Mhm.
So if you're squeezing that bag and it's flatline, that's no ventilation.
Right.
You're in the wrong place.
Right,
Mhm.
right.
So it's not about the tube being in the wrong place. It's about recognizing that the tube is in the wrong place.
Right.
And what are you gonna do
Right.
about it? You know what I'm
Right.
saying? Does that make sense?
Yep.
So I like to tell my students, flatline, when you're ventilating, means no ventilation.
Mhm.
First, because anybody could, and panic, drop a tube, you did everything perfectly
Yeah.
except the
Right.
BBM
Didn't hook
piece.
them up,
Exactly.
yeah.
And that's important, right?
Right.
Again,
So-
it's that air movement, it's not the tube.
Exactly,
It's-
yeah.
So I want to talk to you guys and I want your input on numbers. What's the significance of numbers in a patient, whether they're dead or not, managing an airway?
The numbers that come to mind for me, so first of all, normal, 35 to 45 for the end tidal. And then when I see an end tidal creeping up, so going above that normal 45 and up, I'm thinking that this patient is not ventilating properly. So, you know, overdoses or asthmatics who are tiring, or just anybody who's becoming apneic, their oxygen is going to be above 98% if they're healthy for at least 5 minutes
Right.
probably.
Mhm.
So you won't start to see a change in the O2, but you'll see a rise in the CO2. So that's when I use CO2 in tidal for patients, and then, you know, particularly looking at those that have the increased levels. For those who, another number, I would say 10 is another number that we see cited in the literature quite a bit. Mostly those are the ones that studies have shown that they tend to be more futile, like the resuscitations, if it's consistently 10. So in a lot of EMS protocols who terminate resuscitation on scene, you'll see that number used. If there's end tidal consistently at less than 10, those are the ones that we have seen that don't survive. And when we say survive, you may get raw, so you may get a pulse back, but then is that patient going to leave the hospital?
Right.
And if they leave the hospital, are they going to be neurologically intact? So that's what we care about, not just about getting ROS.
And I think that's where we focus a lot on pre-hospitals. I
Of
got a pulse
course.
back, I'm good, but
Yeah.
what's the likelihood of them being viable to
Right.
to live
Yeah.
independently, right?
Right.
Right, exactly. So I would say those are the two numbers. And then outside of really airway, but when you talk about sepsis, you'll see a lot like of people kind of cite under 20, under 25, anything less than 35 essentially. They should
Can
think
I
about
can I
that.
talk about that, because there's so much confusion and I get a lot of medics who ask me and we have to I explain it to them, but I want you guys to explain if you can. Less than 20, isn't a septic patient acidotic or acidic?
Mhm.
But yet I have a number that shows me he might be respiratory alkalytic. I'm confused. That's what I hear all the
Yeah.
time. Right?
So-
Did you hear that?
Yeah,
Sometimes,
no.
okay.
Well, so it's the terminology is very different when you talk about end tidal. You're not necessarily talking about just a respiratory CO2. So that's where it becomes confusing in
Right.
sepsis. Sepsis is acidotic, but it's a metabolic acidosis. So the end tidal becomes more like the bicarb. So it's very, very confusing if you think about end tidal in the terms of respirations only. So if you think, respiratory acidosis like we're talking about, you expect the end tidal to be high. But metabolic acidosis, you expect the CO2 to be low. So that's why you get that CO2 difference like that
So
as well.
so we're safe to say, for simplicity,
Mhm.
in a metabolic state of acid, I'm in a metabolic state of acidosis. So I'm metabolically acidic because of sepsis.
Mhm.
It's a metabolic process. My respiratory is trying to compensate for the metabolic process. That's so he's acting as a buffing agent.
Yeah.
That like bicarbonate, right? So
Mhm.
he's acting as a buffing agent. So he is blowing off he blew off all his acid.
Mhm.
So
All CO2.
all his CO2.
Mhm.
So the respiratory, the acid that's produced on the respiratory level, he's blowing all that off,
Mhm.
trying to compensate for
His
the metabolic process, right?
Right. Yeah.
Okay. So with these patients then will be we expect them to be tachypnic as well.
Mhm.
Okay.
Yeah.
So those are some key findings we could look at when we assess airway is I'm febrile, I'm tachypnic,
Mhm.
and now my CO2 is low. It's
Mhm.
showing me on a respiratory acidotic state,
Metabolic.
acidosis state,
Mhm.
but we know it's a metabolic process
Mhm.
or issue. And I guess also we will have some type of high index of suspicion that there's an infection involved.
Yeah, of course. And then that's when you assess this alertum and go down that path. But I think, like you said, making it simple. If it's high, you're thinking that they're not breathing
Yeah.
all too well. If it's low, they're probably producing some sort of acid. Or like if you're down for a very long time after a code, then you become very acidotic.
Right.
That's the same case as
Same.
the metabolic acidosis.
Mhm.
So I would just use it for respiratory acidosis and metabolic acidosis. We really don't care too much about the respiratory alkalosis
Correct.
and metabolic
Yes,
alkalosis from
perfect,
that.
makes sense.
Mhm.
So back to the airway management. So let me come up with a scenario to kind of put it all together, kind of put the icing on the cake. So I had an asthma. Let's use an asthma patient.
I don't intubate asthmatics. Sorry, I'm out of this.
That's,
Yeah,
that's a failure of treatment.
Yeah.
I want to talk about that because I got my opinion on that too, and I'm kind of siding with you. Say I mean, if I'm intubating an asthma patient, they're out the door.
Exactly.
You know,
Yeah.
they got one foot in the grave and another banana
Mhm.
peel, right?
You're showing up too late or you did something wrong.
Yeah. So all right. So let's scratch it. Let's make it a different patient.
No, I like asthma. Let's
okay.
do like we're at the end of the road asthma.
Okay. So we're at the end of the
We're walking
road.
in and to shift, someone else was already managed.
Well, what I'm getting at is maybe I won't put it into scenario, but I want to come back to that scenario we can
Mhm.
talk about. But I have a patient that I'm on the fence
Mhm.
that I think his breathing is headed to becoming inadequate where I'd have to intervene at this point. So I'm looking at this patient. So it's safe to say I see the accessory muscles. I see my SATs are sitting in the low 90s, and like I said, that's not 100% reliable because it could fluctuate. There's always so many things that could change that. But I see this patient. He's in distress, obviously, talking one or two words at a time. Accessory muscles, tripoding. Can I look at my end-tidal CO2 and start seeing that incline start to increase to say his respiratory system is starting to fail?
Absolutely.
Is there a number we look at? I know we know 35 to 45 is
Mhm.
normal, but do we say like when he hits 50, does he hit 55, 60? Like,
Well,
whoa.
it's a trend because I'm assuming that you would have put the patient on end-tidal, when you first
Initially.
saw him, right? So let's say initially it was normal, but normal, you need to know that about you. So normal, let's say he was already at 36,
Okay.
right? And so 5 minutes later, there's no improvement in all the things that you're doing, and then you start to notice it goes from 36 and now it's 45. Well, that's still normal, but he started at the low end of normal. So
Right.
something is happening. He's
Okay.
he's starting to tire out. And then you see it go up even more and even more, then that's when you know. So it's not necessarily, patient's, CO2 is 50, intubate, or you need to be concerned. It should raise suspicion. But when you see the trend, it go
Okay.
up from one number to the next, and that's when you need to start worrying.
Okay.
And just to emphasize a point that Dr. Walker made is that your starting point is going to be different based on what the chronic illness is
Right.
of that patient. Who's usually calling in respiratory distress is somebody with chronic illness.
Right.
So that means that those numbers might already be different from normal, and that's normal for them.
Yeah.
Which is why you want to think about it as a trend, because if normal for them is 30,
Hmm.
Right.
then that's already abnormal. But you might when you first show up, they might be doing okay at 30, but then over a period of time they're getting worse. But now they're worse, but at normal.
Yeah.
Right.
Or like
So-
especially COPD patients, their
Right.
entitles will be higher than 45
Right.
sometimes.
Right.
And so you might get somebody who's already 50, and that's where they live. So like
Right.
you said,
So I guess a safe way to say is get that initial end title and the presentation.
Mhm.
So he's presenting to me mild distress at 50, still mild.
hmm
Yeah.
I have my benchmark, I have my baseline.
hmm
Now I see that his difficulty breathing is increased, his moderate now. I look at my end titles at 60.
Mhm.
Now I'm starting to see the trend.
Right.
Yeah, exactly.
Now I probably need to intervene.
Mhm.
Whether I go to a non-rebreather, or maybe
Right.
I was at a non-rebreather, now
CPAP.
CPAP,
Mhm.
Yeah.
now or in the
Your
next
next
next step. So
Mhm.
still, we're going to do it in a stepwise fashion
Right.
as well.
Mhm.
Cool.
Yeah.
Good, 'cause I think that's a good tool. I don't think we utilize it that way.
No, yeah, we use
You
it for
know?
sepsis a lot now,
Yeah.
but definitely like managing the airway. I mean,
Right.
that's
Yeah.
number one.
Right. Okay. So let's get to that asthma patient, because I always talk about that asthma patient because I think, and I think I probably we all could say all professions do this. Some people are more aggressive than others.
Mhm.
What I like to say, and correct me if I'm wrong, and I hope I'm not wrong because I've been saying this frequently, is to my students is I like to give my students, I like to relate everything in medicine to something that they could relate with, so
Right.
they could say, wow, it makes sense, I understand it, I can process it. We have an asthmatic. Obviously, the body automatically is going to try to compensate for whatever was going on, using accessory muscles, tripoding, doing all these things. I would say the best thing we can do is help the body compensate by opening up airway. So get the bronchodilators on board, get them quickly on board, because if he's still in the phase of compensating with an adequate airway, your bronchodilators, not just a butyral, could be apnea, mag, whatever. Your bronchodilators can help out, and then he never declines.
Right.
But sometimes we tend to be a little aggressive because I want to be aggressive because I haven't intubated in 2 weeks and this is a great opportunity to get my skill in. Or I'm so nervous, I had a bad experience
Yeah.
of an asthma and I don't want that again, so boom, I put them on intubate.
Right.
You know, or I don't know what I'm intubating. You know,
Yeah.
so
Yeah.
you have those different. I can come up with so many scenarios of why we
Right.
intubate, but we fail to realize what is the outcome. What is the permanent scar we develop on this asthma patient by dropping a tube in them? And what I do tell them is, it's like a computer. Your computer has a memory. You could delete everything, but it still has the memory. The hard drive is scarred. It has its memory. So when the body is compensating on its own, who knows best to compensate but the body itself, right? So when the body is compensating, you came, you sedated and dropped a tube,
Right.
the body stopped compensating because now you took over breathing, right?
Right.
So when that body reaches that same threshold or that platform where you dropped the tube,
Yeah.
the body stops because he wants what? The plastic cigar, right? He wants that ET tube. So, but if I'm not there to give it, then the patient deteriorates quite quickly. Or I was so aggressive that the body could have compensated a whole lot longer, but because I did that, dropped the threshold, kind of like a battery that develops a memory, right? Is that the same concept?
Well, yeah, I mean, definitely one of the questions that you always ask pre-hospital and in the ER is, one, how many hospitalizations have you had in the last couple of months for an
Right.
asthmatic? Because that gives you a gauge of how bad this is. And then you want to know how many ICU stays. And then finally, how many times you've been intubated.
Right.
You know, that gives you an idea of exactly what I'm working with this
Severity.
airway, how bad is your asthma. So those are things that you definitely want to take into consideration. Once they're intubated once, that history is going to always follow
Right.
them. I think that...
When you say history's following that, they we intubated quite frequently after
yeah,
that?
exactly,
Okay.
exactly. And also it might be a little bit biased too, because I think when you know an asthmatic has been intubated, you
You're
tend
more
to
likely.
you're more likely to intubate because
Right.
you're like, I knew you failed
It's
at
like you
some
got
point.
forgiveness. You're like, okay, it's not my fault.
Yeah.
The treatment's not failing.
Right.
So should I be a little more aggressive with medication? Maybe should I, if they're at the age criteria, no
That's true,
history, go with epi maybe immediately. Give a butyral, but go with epi right away, or go with a mag
Oh, you
drip.
definitely want to be way more aggressive
More
than those
aggressive.
who've had more ICU stays, who've had intubation.
No matter how they're presenting at
Usually-
that moment.
When I have an
Well,
asthmatic who says that they've been intubated before, frequently with an asthmatic who comes in who is just kind of a routine kid with asthma, you kind of have these steps you go through for how much what medications you're using to treat. If they come in and say, yeah, I was in the ICU for 2 weeks and I was intubated 4 times, I'm not really going stepwise. I'm just saying, okay, here's all the treatments I have.
Like you say, yeah.
Yeah.
So
You
you're
know.
doing the MAG, you're doing the all
Right.
three, the
Yeah.
continuous at one time, like for that type of patient.
While they're sucking on an nebulizer, I'm starting an IV
Right,
to
exactly.
So,
Yeah.
versus they had no intubations, they haven't been
Yeah.
Right.
hospitalized. Okay,
Right.
try
And
to
you
do
can
all.
always try this, see how that works. If
Yeah.
you're still not feeling great, we can go on to this. But if
Mhm.
they have a history of being intubated and that's serious, you want to get ahead of it.
Would that same concept apply to COPD patients as well? Multiple intubations, what's the likelihood? Is it slightly different?
It's different, yeah, because COPD it's not as acute of a process as asthma is. So that one you have time, and it's not
Okay.
something that's like scarring, you know, like how many intubations. So if you got
Right.
intubated, you probably had like sepsis too, and I mean those people are sick
Yeah.
and they have a lot of chronic
And if
conditions.
you
so it's not
intubate
the same.
those, I think a lot of times when you get those real chronically sick COPD patients, it's hard to get them off that ventilator, right?
Yeah, yeah. I mean, they have similar pathophysiology to asthmatics as to why we don't like to intubate them. I mean, for asthmatics, there's several reasons, but one is the fact that when you put the tube in, you get a sigh of relief, and you're like, oh. But you forget that was not even their issue. Their issue is not that they needed a tube. They need some sort of bronchodilators.
Right.
So often when they get intubated, some people forget the asthma treatment. Like they still need nebulizers.
Yeah.
They may need epi, they may need mag, like Solumedrol, like that still applies. But people think just because you're taking over the airway, then you've solved their
Right.
process. You haven't. So that's one reason that you think twice about intubating asthmatics. The other reason is that it's mostly the vent management is a problem. So some people think, oh, it's just hard to intubate asthmatics. Well, no, the process is still the same.
Right.
You're still going to look for the cords and
makes
use what
sense.
you need, but what do you do with that vent afterwards?
Right.
It's like we talked about a little while ago, like if you are intubating someone with metabolic acidosis and they're breathing so fast to expel that CO2, then you intubate them and put them at whatever rate you want, 12,
Right.
and they decompensate on you because you didn't match their airway.
Right.
Asthmatics are similar in that you have to be adjusting like minute by minute, how much do they need to, remember they have a prolonged expiratory phase.
Right.
Are you accounting for that on the
Yeah.
vent? Are you allowing for there to be breath stacking where the air just accumulates and accumulates?
Boom, pneumo.
And now, they either have a pneumothorax or they code and you
Right.
can't get them back.
Right.
Those are a lot of things you got to think
Yeah.
about. So that's why we hesitate when we can, to do, airway intervention like that. We get onto the mag, we get on the steroids, everything we can do prior
Right.
to intubation.
So I guess, so I want to say, based on what they said, is be aggressive with asthmatics. Dropping the tube is not the only way of being aggressive.
Yeah.
Is not the best way of being
It's
aggressive.
not the best way of
It's
being
the worst
aggressive.
way of being
Right,
aggressive.
because
for
in
asthma.
medics' minds, they'll be like, I'm an aggressive medic,
Mhm.
I'm an intubate, and it's not. It's about being aggressive with the
In the right
medication
way.
that's going to treat them.
Yeah.
That's going to
Right.
help them. So be aggressive that way. Be quicker.
Mhm.
Recognize that the nebs didn't work. Recognize that what's my alternative.
Mhm.
And be quick to utilize that.
Yeah.
It's kind of like, I like the metaphor you were using with your students in terms of you were saying that it's a more complex process in terms of like their compensation. The human body is very good at compensating.
Right.
And is much better at compensating than we
We
are
think.
compensating for it.
Right.
And when you intubate an asthmatic, their body was already doing a very, very complex process
And we
of
stopped it.
compensating. Then we stopped that, and then we
And then
brought
tried to
in,
start-
and
start
then we
over.
brought in with our slide rule to
Mhm.
try to do the equivalent with our like vent machine.
Right.
And our vent machine is really clumsy compared to the human brain in
Right.
terms of how well it can compensate.
Yeah, we're watching a picture on a big screen. Now all of a
Yeah.
sudden they bought me this little 2-inch screen. I can't see the picture.
And you're trying to do
you
the
know?
same thing, It's the ability to compensate. Once we take control, is not as good as their own ability to concentrate.
Good deal. So I want to end it with one other piece in cardiac arrest, because I think this is always something that comes up frequently. Is on a code. We all know that chest compressions is probably the most important piece on a cardiac arrest, but it's hard for a paramedic to put aside airway management.
Mhm.
And in the code, a lot of us like to jump right into the ET tube. I'm one.
Mhm.
I'm one. And I think it's probably best to understand why I grabbed the tube, right? Versus why I just ventilated BVM. I try to grab the tube. I could drop the tube most of the time with somebody compressing, but you get somebody who's brand new and novelist, who's just you rely on what you learned in school and that technique, right?
Mhm.
Stop CPR, hold on a second.
Right.
But we do it, I think, more so because we don't know what's in the belly.
Right.
Not too many people die, and they know there's a crystal ball, so they were NPO for 24 prior.
Mhm.
So we probably got a full belly, so we worry about all that air going in the stomach, moving the patient from the floor to the stretcher, from the stretcher to the ambulance, from the ambulance to the hospital. All that movement, all that food, all that air it's a ticking time bomb for vomitus, right?
Mhm.
So we drop a tube. So I don't know, is there any set precedents or ways students can say in a code, I'm going to go right to this airway?
I think you should follow the 2015 AHA guidelines. And just because they have, they did the due diligence and they look at all this research and, things change. So in another 10 years, who knows what we'll be doing. But they've reversed it for us. They confused us all. It's CAB now.
Yeah.
Right.
So, CPR first, defibrillation, and those are the only two things that we've seen for sure that make any kind of impact. The other things that we do may or may not benefit, but those are the things we see for sure. So once you have gotten someone on the, CPR, they are attached to the pads for defibrillation, then you can start to manage the airway. Because they can go for a while without breathing. We do the pre-oxygenation thing, and we've learned a lot more about the breathing mechanics of people, but they can go for a while
Right.
without that. To your point, It's about logistics. So what's easier for you?
Right.
So let's say I'm in the ER and it's just myself and another person. My choices of what I'm going to do in the sequence will be different than if I have 6 people around me.
Right.
So if you can delegate, then absolutely. If somebody can be doing CPR while someone's doing the airway, you can do pit crew method, then that's appropriate. But if it's just 1 or 2 of you, the CPR defibrillation is what's going to matter for that patient.
Nobody dies and all the oxygen just falls out, right?
Right.
So there is some oxygen in there, we just gotta circulate it.
And
Right.
what was really impressive to me was actually seeing the data show, like, that's now advocating in community CPR only, compressions only.
Mhm, yeah.
And that it's showing that if you teach even just lay people, just do compressions, don't
Yeah,
even
that
give
was pretty
breaths.
impressive. Yeah.
Then they're not giving any breaths at all, just compressions, and they're having similar outcomes
Yeah.
to people who are giving breaths.
Do you think
So that tells me that
it works?
breaths, it works. you
Mhm.
know?
The compression. So
Yeah.
do you think in the future, do you foresee, or even now, doing compressions with maybe with a assisted device
Yeah.
and maybe some supplement oxygen? Does it with the recoil of the chest, does that create a negative pressure that might be sucking in some air, passive air?
Yeah, it is, and they have all these fancy devices that you can put on now to allow you to just exhale. So whenever you press down on the chest, it intermittently changes with these devices. But AHA came out on those devices too and found that there was no difference in outcome. And the devices you're talking about too, with the like load distributing bands
Yeah.
and the pistons,
Yeah.
those are good too. Logistically, sometimes when you don't have the personnel there, but then they also have their adverse outcomes, like more rib fractures. I think last I saw was like a 30-to-1 ratio versus manual compression.
Wow.
They've had traumatic or they've had aortic ruptures from that, liver injuries and hematomas. So that's not without its pitfalls as well. But I think to your point, logistics is like what's important there. We know what goes first. Now, do we have the personnel to be able to accomplish that? If you have someone that's able to intubate, then do it. I think it frees someone up. It helps you not to worry about the airway. You don't have to worry about whether you can bag and whether you can ventilate. But we're just trying to, I think we as a medical community, to say, hey, that's not the most important
not the
thing.
first
Like we
priority.
used to, like we
Yeah.
used to.
So to what you're saying, that 31 rib fracture, aorta issues, do you recall like the band versus the piston? One
They were the
causing-
same.
They were the
yeah.
same.
Mhm. Yeah.
Wow,
I
interesting.
looked into that too to see.
Yeah,
'cause
one was better than
First,
the
they were
other.
citing the low distributing, and they said the pistons also have similar outcomes too.
Oh, okay.
Yeah.
Interesting.
hmm
Well, Doc, thanks a lot, both of you guys, for coming out,
Appreciate
doing
your
this
lecture.
phenomenal airway lecture. Students, I'm sure will appreciate it. Once again, guys, if you have any questions for myself or the docs about this presentation or even this look back, feel free to drop me an email at fmarquez@omi.edu. Stay tuned for future podcasts. Thanks.